considerations for the optometrist in relapsed or refractory multiple myeloma, mitigating and managing ocular adverse events. This activity is accredited for 1 hour of COPE credit and is supported by an independent educational grant from GlaxoSmithKline. To earn CE credit for this activity, please visit the link to complete the post-test and activity evaluation at the conclusion of the activity. And with that, we'll turn it over to our expert faculty.
All right. Thank you all for your participation with the pre-questions. So, we talked about financial disclosures. So one big disclosure, which is a non-financial disclosure, but it's a disclosure to the topic for tonight's presentation, is that there is an update regarding belantamab, which is, the BCMA targeted treatment that's available for RR multiple myeloma. So in November of 2022, this past year, the medication was voluntarily withdrawn from the market. So I'm disclosing that, but I think there is definitely importance in this evening's presentation of how this medication is gonna come across our clinical experience, and then potentially other ways that we may see patients with this and may need to screen them. So I will be kind of getting to this and helping make that case as we progress through the presentation here. All right, so brief background of what multiple myeloma is. And obviously, when we do this presentation in collaboration with our oncologist, this kind of slide takes them like 15 to 20 minutes and they focus a lot on it. Obviously, this is coming from the eye doctor's background of kind of highlighting what multiple myeloma is and, why it's important to us. So, obviously, whether it's through our clinical experiences or even outside of work, we've all at some point, come across multiple myeloma. And, there's really two reasons why this is very important. One is it is the second most common type of blood cancer. And secondary to that, there is no cure. And so, these patients are going to, continue to have findings and require treatments, which may have ocular side effects. So, multiple myeloma originates from the plasma cells, which we all know back from, undergrad and even our graduate studies and from immunology. Plasma cells are B lymphocytes that are made in the lymphoid organs, and they are involved in making antibodies. And so by a mechanism that we don't fully understand yet, there is a neoplastic transformation in these plasma cells. And so they start functioning abnormally, and they start making a whole bunch of proteins, specifically, antibodies. And then those proteins start getting deposited throughout the body, commonly places like the bone or the kidney. However, us as eye care doctors, we know that it also can affect the not only the eye itself, but the orbital tissue as well. And so that's where kind of the diagnosis can be made. And a lot of times with the ophthalmologist or optometrist, we could potentially help, with that diagnosis. This slide on its own, going over the different stages of multiple myeloma, I think it could be a presentation on itself. So I'm just kind of going to highlight some of the important stuff that are pertinent to this evening's presentation. But, I think we all have come across MGUS, which is monoclonal gammopathy of unknown significance. And, one of the characteristics that helps differentiate the different types of multiple myeloma is the M protein. So with MGUS, this is basically a precancerous condition where, the oncologist will make this decision and it's, not 100% certain. This may turn into cancer, it may not turn into cancer. But, kind of what's important to us is that this is something we do see sometimes clinically with patients presenting with different, presentations of this, of either their eyes or the orbital tissue. And so basically as that M protein level increases, the patient can progress to different stages of multiple myeloma, with remission basically being when treatment has been started and the disease process is having a response. However, either with resistance or with inability or the melanoma basically coming back, that's where we get to the relapse or progressed kind of stage of multiple myeloma, which is the interest of this evening's presentation. So another factor why this is so important is that there are ophthalmic manifestations of multiple myeloma that we as eye care doctors may be the first ones to see and help start the process of the workup to make this diagnosis and start the treatment as soon as possible for these patients. And so we all kind of know this. You can get a presentation of proptosis in a patient where there's actual deposition in the orbital around the globe, causing that proptosis. And so this should kind of be on our differential if we're seeing a patient with proptosis. The other, for our retina nerds out there, this can present as vascular occlusions in the posterior segment. So once again, being on our differential. And the most important structure of the eye, the cornea, we can find deposits of those proteins in the cornea that can kind of help with this differential to make the diagnosis of multiple myeloma. So once again, this is a way that us as eye care doctors can really impact our patients' lives and potentially save them and prolong their survival. So very briefly, what treatment options do we have available for multiple myeloma? This is really going to be a decision that's not made by us. It's going to be made by the oncologist, and it's going to be tailored to the patient's overall general health and, other potential comorbidities that they have. But, traditionally, there are three pillars of first-line treatment. There are immunomodulatory agents like thalidomide. There are protease inhibitors like bortezomib, and this is a medication that, for some of us out there, you may have encountered in your clinical practice, as this medication has been correlated with chalasia forming in patients. Luckily, these chalasia are not visually significant, and they do resolve with, basically finishing the treatment. So once again, another kind of potential ocular finding that you may see in a patient that has multiple myeloma who's getting a first-line treatment. And then lastly, we have our targeted monoclonal antibodies that are directed towards CD38. And then in many cases, as we know, when we initiate these treatments, patients may have, a big hit to their bone marrow. And so these patients may progress to need stem cell transplants. If they've got a healthy bone marrow, that will have an autologous transplant, and then those that don't, they'll consider an allogenic transplant. Once again, another reason why this is important to our day-to-day is that this is a totally other entity. Patients who've undergone a bone marrow transplant, we know that they can get an entity in itself called ocular graft versus host. And so another important kind of disease entity, if you are near a bone marrow transplant center where you may be helping manage those patients when they have those signs. Obviously, that's another topic that's near and dear to me, and I can go on all night talking about that, but just kind of once again highlighting why this kind of impacts us as well in our day-to-day. So now getting to the focus for this evening. So for R&R multiple myeloma, basically, this is where we potentially have resistance. And we know with patients with multiple myeloma, when resistance emerges, their overall survival rate is 13 years. Now, if the patient fails 3 or more different classes of treatment, their overall survival rate is 6 months. And there is some data out there that shows the patients that are resistant to the anti-CD38, their survival rate may decrease as low as 3 months. So this is kind of the reason why there's been such an interest with our oncology colleagues to really have better treatment options for this group of patients, just because their overall survival rate is limited. And if we can offer better treatment, we may really be able to impact not only their survival, but their quality of life. So, what options do we have for patients with R multiple myeloma? Well, obviously you can consider previous treatments that worked in the past. However, many times, the reason they're here is because they've had resistance. Could transition to a second or third generation treatment option, or try something, like a selective inhibitor of nuclear export. But kind of as mentioned previously, the overall survival rate in these patients is not that long. And, this has once again created the interest in these BCMA targeted therapies, or belantamab specifically is what we're referring to. And the reason why this is kind of revolutionary is that we do know that these BCMA receptors are on all multiple myeloma cells in the body. And so basically this allows for targeted treatment for all the cells that we really want to basically get rid of in these patients. And, this receptor is involved with many of the functions of those multiple myeloma cells that keep that cell alive. So basically we can cause basically a targeted death of those multiple myeloma cells and really help improve the patient's survival rate. Now, what's the correlation with us as eye care doctors? We believe that, there is a correlation with the ocular side effects that can go along with these medications, because this receptor is involved with something known as MMAF. And we believe that with MMAF, it's causing a spindle poison to be synthesized, and that is what is causing the ocular side effects that we're going to get into in the upcoming slides, that really are more focused on the corneal epithelium. And so, that's what's really interesting about the side effects that we're going to get into. They are limited to the corneal epithelium. They don't extend deeper into the cornea for the most part, or into the eye itself. And so this has kind of helped us in understanding why these patients are getting these side effects, because we all know the epithelial cells are regenerated by the limbal stem cells. And so likely there's a correlation with these side effects and where these cells are kind of being made. And we'll kind of hit on those in just a moment here. So before we jump into the ocular side effects, I know that's why everybody's here tonight. Let's talk a little bit more about what belantamab is and what the studies have shown with this medication, because I know I talked about how the potential here is great, but let's talk a little bit more about the studies. So the people that came up with the studies had great names. So they've all been DREAM, obviously ranging from DREAM 1, and the numbers continue to increase. So with DREAM 2, this was a phase 2 randomized study looking at belantamab at 2 different doses with patients with RR multiple myeloma. And they basically continued these infusions every 3 weeks of this medication until either the side effects were intolerable or the disease progressed. And so it was from this study that there was an accelerated approval for belantamab in September of 2020, and basically based from those results. So what were those results, and why were they so groundbreaking that there was that accelerated approval? So looking at the lower dose treatment arm with 13 months of follow-up, about 32% of these patients achieved overall response to the treatment, with 7 kind of being in that complete response area, and 18 being with a very good partial response. And overall, these patients received the treatment for a duration of average of 11 months. And their overall survival was found to be almost 14 months. So if we're kind of going back to what we were talking about earlier, if the average survival rate might be as low as 3 months, increasing these patients' survival rate to almost 14 months is huge. And then additionally, only 9 of the 95 patients had discontinuation of treatment, with 3 of those being due to ocular side effects, and we'll get into depth in the upcoming slide. So, then obviously progressing with DREAM 3, this looked at belantamab compared to a conventional treatment of pomalidomide with dexamethasone. And so with the results from the DREAM 3 study, this is actually what led to the voluntary withdrawal of belantamab from the market. And basically the reason for that was that the study didn't meet its primary endpoints with survival, but of more importance to why it factors to us is that 80% of the belantamab patients had ocular side effects, with almost half of those, being in the higher grade, which we'll get into what the different grades are, but there are 4 different grades when it comes to grading the keratopathy associated with belantamab. And so this was kind of the reason why the company voluntarily withdrew this medication. So bringing it back to the initial disclosure that I made, but what does this mean to us now? So yes, there are no more patients currently being accepted, but this treatment is available via compassionate use. So there may be patients that will be finding their way into your clinic. So it is important to be aware of the potential side effects and how we manage them. Also with the DREAM 3 study, they are still ongoing and collecting data. So there are patients who are still going to need to be followed. And then there are 2 additional DREAM studies, DREAM 7 and DREAM 8, that are ongoing, looking at different options, which we'll get into with the treatment for RR multiple myeloma. And so once again, depending on the results of these studies, the medication may become available. I also think that, with multiple myeloma, these targeted treatment options are really going to be the future. So even if it's another medication, we may be seeing similar side effects. So it is good to have kind of a basic understanding of what's going on here and how to manage it. So let's talk briefly about DREAM 7 and DREAM 8, just to hit that. So basically, these studies are looking at using belantamab kind of as an adjuvant with a conventional treatment versus an overall conventional treatment. So we can see DREAM 7 is belantamab with bortezomib and dexamethasone. This study is obviously ongoing. And then we have DREAM 8, which is belantamab with pomalidomide and dexamethasone versus a conventional treatment option. So once again, we're curious to see what the results will be from these studies, but this may be another way that you might be seeing patients coming into your clinical experience undergoing belantamab infusions. So let's focus on the important stuff. Why does it matter to us? What's interesting is this is a systemically infused medication for these patients. And, if we're looking at the overall side effects, you would kind of think that the systemic side effects would be more common. But when we're looking at things that we'd expect, for example, things like thrombocytopenia, anemia, neutropenia, they're actually presenting less common than the ocular side effects. And we can see here 72% of the patients in the DREAM2 study had ocular side effects. The other thing is half of the patients also had a change in their best corrected visual acuity. And just to be clear here, only a fourth noticed blurred vision. So there are changes we're seeing because we're checking their best corrected visual acuity, but patients aren't necessarily noticing it. So this is kind of really an important factor that we are, when we're seeing these patients in their screening exams, that we're checking their best corrected visual acuity, because that may be something to help judge and give recommendations to their oncologist of pursuing treatment or not. And then about 15% had dry eye symptoms. I think what the take-home point here is that most patients, the onset of the keratopathy was by 37 days, and most patients had some sort of ocular side effects, usually by their fourth infusion. And just being clear, the infusions are done every 3 weeks, and then as part of the screening process, the patient gets a full eye exam, and it needs to be done within 3 weeks of the first infusion. And then the patients then will return every 3 weeks for an eye exam to basically help determine if they can continue their infusions. And those basically happen at 3-week increments. The other important thing is that with the ocular side effects, all of them resolved with either holding or stopping the treatment. So there has not been any permanent significant vision loss in these patients. So that's the other reassuring thing that's good for us to know as eye doctors when we see these patients. That's something we can kind of definitely assure them. So now let's get into the nitty-gritty here with the scaling when it comes to these patients who are on belantamab infusions. And the great thing is you don't have to memorize this, because in any case that these patients require screening, they're going to bring you the paperwork, you're going to fill it out and then get it to their oncologist. So there are 4 different stages, and then based on those stages there are recommended alterations in their dose or their infusion frequency. So for grade 1, this is basically a patient who has mild corneal staining, and really just one line change in their best corrected visual acuity. And in this grade 1, we would recommend that the patient continue getting infused. Moving on to grade 2, this is where we're seeing more moderate corneal staining on their anterior exam. And then we see a change in their visual acuity by 2, but no more than 3 lines. And with grade 2, the recommendation is that we hold the infusion until either they're at grade 1 or the keratopathy resolves. And then grade 3 is when we're seeing more severe corneal staining. And then here we're having more than 3 lines change in their best corrected vision. And it's recommended for grade 3 that these patients, obviously their infusions are held until they're either at grade 1 or better. And then there's a consideration that when they get to that point, to consider a lower dose for their following infusions. Now, grade 4, really the defining factor here is that there's an actual epithelial defect. And the recommendation for grade 4 is that we actually just stop the treatment. I mean, you could consider a lower dose infusion, but the overall recommendation is basically stopping the treatment from that point. So what are the ocular side effects that we're seeing in these patients? My experience has been microcystic-like epithelial changes. This is the most likely visually significant finding that we're seeing with these patients. And here we've titled this microcystic-like epithelial changes, just to be clear, because, commonly when we see microcystic changes in the cornea, it's usually responding to something else, some other pathology going on in the cornea. So for example, the intraocular pressure being elevated, in that situation, we'll see microcystic changes. Or if there's any sort of endothelial pathology in the cornea and the endothelial cells are not functioning well and there's corneal edema, then we'll see microcystic changes. The difference in this factor is that we found that these microcystic-like changes are only contained within the epithelial and the subepithelial space. The underlying cornea is healthy, and there's actually no corneal edema that comes along with this condition in terms of our experience. The other thing is that there is a very stereotypical pattern that these microcystic changes are appearing. So they present in the periphery at first, and then if the infusion is not held, those microcystic changes will continue to progress in a central-like fashion. And so we do know that from some of the preliminary studies, if these progress, then you can get more permanent corneal haze or even corneal ulceration. So this is kind of the importance. If we're seeing this and the vision is changing, we should halt treatment. And at first, this is a little difficult to see at the slit lamp. But kind of going under high magnification and considering things like sclerotic scatter or retroillumination, that's what kind of helps identify this early on. And then the other component with the side effects that we're seeing is dry eye, and kind of things that go along this: punctate epithelial staining, superficial punctate keratopathy. And what's also stereotypical is with this is kind of this whirl pattern of the staining that we see with this kind of dry eye findings that we're seeing in these patients. Now, I've kind of given two things that kind of give away where we think the pathology is. One is the pattern of the microcystic, where it goes from peripheral to central, and then the other is the whirl pattern of the staining. So here are just kind of some other photographs kind of trying to help identify what those microcystic-like changes look like. You can see here with kind of retroillumination, it does help highlight those microcystic changes. And then, for me seeing this, what's similar, what looks like this, it actually doesn't look like the microcystic changes that you see with corneal edema or elevated intraocular pressure. To me, it kind of looks more similar to patients with like Meesmann corneal dystrophy. Obviously, this being more peripheral, with Meesmann's, it's more diffuse, that being more of a genetic corneal dystrophy. But it's very similar to what it looks like when you see these patients. Obviously, the difference, someone with Meesmann's, it's not going to improve. In these patients, it will resolve when we hold the infusions. Here, just some fluorescein staining, just demonstrating from a patient that one of our patients, that kind of showing you that central progression of those microcystic changes from periphery to the center of the cornea. Now, with the fluorescein staining, we're all used to seeing that kind of dry eye stereotypical staining where you see kind of like a patchy inferior patch of that PEE. But with these patients, as it progresses, we see more of this whirl pattern, very stereotypical and similar to what we see with limbal stem cell deficiency. So once again, kind of pushing us that there's something really focusing and going on with the epithelial cells in this case. So, obviously, to the best of our understanding, what we think is that, that MMAF is leading to that spindle toxin that, is basically with payload deposition in the limbal stem cells, that those toxic cells basically are sticking around and they're not going away. And so they're following that pattern where they start in the periphery of the cornea and progress centrally. And then the other thing is that, we believe that toxicity is affecting the overall limbal stem cell function. And so that's kind of why you start seeing these, whirl-like patterns of the punctate epithelial keratopathy. But once again, in both of these situations, when we hold or discontinue the treatment, it completely resolves. Here, this is from a published study that looked at anterior segment OCT in these patients who were being infused and had those microcystic changes. So really here, I just want to highlight to you that really you see this hyperlucent kind of area where those microcystic changes are, but the cornea underneath is healthy and there's no pathology. So really, it's in the subepithelial space and it's not extending deeper. This was also, kind of really opening up the door that we are learning more and more about this entity. This was a study that was published where, they got confocal on these patients before and during their infusions, and they actually found a reduction in the subbasal nerve plexus on the confocal microscopy. So once again, opening up this door that, yes, we don't think that there's pathology deeper in the cornea. However, this may be changing the spectrum of what we think, because there is a potential temporary kind of neurotrophic component to this that may be putting these patients at risk for that worsening ocular surface disease with the punctate staining. So, the good news is that it does resolve with the holding or cessation of the infusions. But once again, opening up that potential door that there may be more going on than what we completely understand. And obviously, we're still in the early stages of fully understanding the pathophysiology here. These are some photographs from a case report of another patient that was in the study, just kind of highlighting for you here kind of what that punctate whorl pattern of staining looks like with that microcystic like changes. And, obviously this patient on the right here is a patient that now has an epithelial defect. So this is grade 4. But kind of once again, I want to highlight to you that even the epithelial defect is kind of very stereotypical to what we see with limbal stem cell deficiency and the epithelial defects that go along with that. So no presentation would be complete without a case. So I kind of want to help review what we've discussed here and share a patient from, the clinical trial, and then have you guys kind of think about what you think the overall stage is here. So this is a 64-year-old female with RR multiple myeloma. And she's been refractory to 4 different types of melanoma treatment. So under compassionate care, she was started with belantamab infusions. And so obviously with her, she did get a baseline screening exam. And it's very important on these screening exams that we're not only getting a very good, accurate, uncorrected vision, but we're getting a really good best corrected vision, because that's something we're going to follow in these patients, because they may or may not be able to detect the changes in their vision at first. And then obviously we want to document everything on the exam. Do they have a cataract? Have they had cataract surgery? How does their posterior segment look? Do they have any macular findings that could affect their vision? And so definitely, once again, there's an importance there of identifying where they're starting out. So in this patient, she had undergone bilateral cataract surgery and her best corrected vision was 20/20. So that's where she is prior to infusion. So once again here, when we're seeing these patients, we're going to see them prior to their infusions. And, our exam is very important in dictating what their treatment option is going to be. And so we really need to spend time. We should put that fluorescein in, let it set in for about 30 seconds to a minute before we examine them. Be on a high mag, obviously consider retroillumination and looking for those early macrocystic changes and epithelial changes in these patients. So back to our patient, she comes in after her 3rd infusion. So she's basically now at follow-up to see if she can continue with her 4th infusion. So here we can see her best corrected visual acuity is 20/40. We do find some mid-peripheral microepithelial cystoid-like changes in her cornea and a mild staining of her corneal epithelium. So opening this up to you guys, first of all, what grade do you guys think this is? So I'll give you maybe about 5 seconds to think about it on your own. And then obviously, what would you recommend in this case? So I'm going to make it easy for everybody, because remember, these patients are going to come with the forms for you, so you don't have to even Google it. But kind of reviewing here what the different grades are. So kind of think to yourself, now that you have all the information in front of you, what grade would you put that patient in, and what would you recommend for treatment? So in my opinion, this patient would fall for grade 2, because she had 2-line change in her best corrected visual acuity with kind of a mild to moderate corneal staining. So with grade 2, as we know, we're going to recommend holding the infusion until either they're at grade 1 or the keratopathy is resolved. And so that was kind of the recommendation for this patient. So we've talked about what we're seeing with the ocular side effects. Now the next question is, what do we do when these show up? And, the conversations we have with the patient. So I have to say, my experience with these patients, they're actually presenting to my clinic very well informed. They've been, gone through the consent process. They are fully aware of the ocular side effects. And in many cases, they're more anxious about the ocular side effects because they've seen graphs from their oncologist where they know 80% of patients get them than they are the actual infusion. And to be honest with you, sometimes the patients are more annoyed by their eye exam because it takes an hour to 2 hours and really stresses them out, because it's basically deciding if they're going to get that infusion that's going to keep them alive versus the infusion that they feel like is not bad at all and takes 30 minutes. So it is interesting. But I think, that's a big part of this is, us kind of providing that emotional support and reminding these patients that, yes, these ocular side effects are real, but what we do know is that they all resolve, and no patients have had any permanent visual effects following the treatment. So, for me, the most important factors in these patients when they're coming in for their screening exam, not only doing a complete eye exam and getting a really good manifest on them, but optimizing their ocular surface. So I am looking at them very strictly. Do I even see any staining before we've started the infusion? And if I do, I'm going to start preservative-free artificial tears. I'm going to consider starting ointments before they go to bed, warm compresses. And then, considering, if they've got more moderate to severe signs of dry eye, I'm going to consider starting, topical cyclosporins or lifitegrast. I have no financial interest, but in these patients, I tend to more lean towards lifitegrast. Some of the side effects are higher with lifitegrast, and I'm specifically talking about things like burning or that kind of metallic taste or blurry vision after instilling the drops. However, we know the onset of lifitegrast is on average 4 weeks, whereas with cyclosporin, it could be anywhere from 6 to 12 weeks. And for these patients, every week makes a big deal. So if I'm seeing these patients 3 weeks before their initial infusion, that 4-week result may help push off any sort of side effects a little bit longer so they can get more infusions before we have to hold it. And then I think there's specific considerations. So any sort of patient that has had prior like LASIK or PRK, we know that they have baseline corneal neuropathy. And so they are already at an increased risk for dry eye and inflammatory dry eye and other kind of conditions. And so in those cases, I'm hitting them very aggressive. And I go straight, to starting topical cyclosporin lifitegrast. If they've got any signs of inflammatory dry eye before their initial infusion, I will consider topical steroids and really get them to the point that they're optimized before starting the infusions. The other kind of difficult entity is you have a patient that presents with a cataract. And we all know cataracts are going to get worse. The difficulty is when they start getting infused, how are we going to know that it's their cataract getting worse versus the keratopathy? And so that can kind of make things difficult, especially when these infusions are so important in the patient's survival. So in many cases, if the patient is stable and we can get that cataract surgery taken care of and they actually have a visually significant cataract, if we can get it taken care of in maybe two weeks or so to get that before their infusions, that would be ideal. But obviously, we don't want that to be the reason that they're not having infusion or treatment. And then obviously after they've been infused, whenever possible, we want to hold off on doing something invasive like cataract surgery just because we don't want to overthrow their response. I think the other factors here is in these patients, although they tend to on average be older, many of them are wearing contacts and soft contacts. And we all know that soft contact lenses do make dryness worse. And so transitioning these patients who commonly wear soft contacts into glasses, we found that to be very helpful in addition to optimizing their ocular surface. If they're super contact lens dependent, a consideration would be scleral contact lenses. As we know, those do help visual acuity, but then also they help with the ocular surface as well in just even typical dry eye patients. So another consideration to think about in those patients. So initially when we were seeing these patients as part of the trial, you start seeing those microcystic-like changes. You start seeing that whorl pattern of punctate staining. And, for me, in a patient with limbal stem cell deficiency, when I've seen things similar to that, some level of steroids have been helpful. And so that was kind of our go-to thing where we would, when we saw that, we'd start them on steroids to see if that would help. At Emory, we kind of looked at a subset of these patients and we found that steroids were not helpful after the infusion process had started. So separate from preemptively when we're trying to optimize our ocular surface, if you see any sort of inflammatory dry eye, yes, steroids are helpful. But once they've started the infusions, the steroids tend not to be as helpful. And we actually found that the side effects like increase in intraocular pressure were worse than any sort of potential benefit. The jury's still out on, topical cyclosporin and lifitegrast in these patients. For the most part for me, most of these patients have some sort of dry eye when I'm seeing them initially. So I've already started them on it, but we still don't know, once they've been infused, does this help at all? So once again, this is something we're looking at further to see if that's helpful. So I think ultimately here, the summary is that, this really highlights the relationship between the eye doctor, the oncologist, but then also the patient. And I've kind of hit on this a few times here, but for these patients, they're very anxious. They're worried about the side effects. And so it is important for us to really be there to comfort them and let them know that no matter what, these side effects are not going to be permanent, and that the potential, the risk and benefit there, and to have that discussion with them. I think also this really highlights the role as us as eye doctors, because we're basically calling the shots in these situations. And so the oncologist is very interested in what our exam shows. And so it's very important that we really have that good baseline exam so we can give good follow-up to the oncologist and let them know if it's okay to proceed with infusion or if we need to hold. So let's hit the post-test questions. So kind of coming back here, I guess I'm going to review actually, and then we'll hit the post-test questions. So I kind of hit this first point in the previous slide of that kind of collaboration and that relationship between the oncologist, the eye doctor, and also the patient. I think I've hit it pretty hard that it's very important that we have a good manifest refraction at the initial visit, but then throughout the screening process, so we can adequately give feedback to the oncologist. I think another consideration, so on their pre-screening exam, we're doing a full eye exam, we're dilating them, and we're looking at the posterior segment. Now, as part of the trial, for every additional visit, we did continue to dilate these patients, probably the reason why their visits were much longer. But we found that outside of that initial screening exam, the additional exams, doing the dilated exam, didn't really reveal any pathology. So that may be something in the real world that, at the follow-up visits that could be skipped. I think it's important, if you have access to slit lamp photography, to consider taking a slit lamp photograph of these patients when they initially present without any kind of fluorescein and then after fluorescein. Ideally it'd be great if they're seeing you and then every subsequent visit they're seeing the same doctor. But even at our institution, that wasn't always the case. And a lot of times the patients were presenting on the same day of the week. So either myself or my partners would be in clinic. So we tried as much as possible for the same provider to see them, but that wasn't always possible. So once again, slit lamp photographs may be helpful for us to kind of accurately judge and monitor them. But once again, that visual acuity is very important. And then I think that the final point here is, we want to help these patients, but then also we want to make sure we're not causing any kind of ocular harm. So once again, really highlighting the importance of us as the eye care doctors in this. And, I do see potential here in the future, the same way we have, screenings for patients on Plaquenil. There's other also cancer treatments, like, for example, with GU cancers that have ocular side effects that we're finding out more recently. But this area of treatment is not going to go away. It's going to continue to find its way in our practice. Obviously, there are additional studies that will be coming out, so it may be available again. But once again, highlighting the importance that we are comfortable in identifying this and in managing these patients.
Thank you for attending this CE activity. We hope it has been impactful for your clinical practice, and most importantly, for the patients you serve. Please proceed to the link to complete the post-test and activity evaluation to claim your CE credit.